All right. Hello, I'm Dr. Preston Parry. Welcome to not First Friday's Fertility Live, which I've done before, but my first TikTok Live. I am really excited to be doing this. TikTok has done such amazing things in advancing awareness on multiple topics. And there are people who are passionate. There are people who care deeply about fertility. And I'm just happy to be on this. Talk with anyone who has anything they want to do, for fertility. This is going to be a good time. And by the way, this is my first time doing a TikTok Live. So if I do something silly, you guys tell me. I'm going to improvise. I'm going to make it work. And I'm just proud and privileged to be here. And, I'm going to talk about random things for fertility. Let's see. I can just dive into stuff that I've been having over the past week. Some of the strangest stuff I've had over the past week is people actually being born with abnormal uteri. So these are people, for example, I had a person who was born twice in the past 2 weeks. I've had people born with half a uterus. And one of them, there was a tiny remnant, and they could have actually had a pregnancy in there, and it could cause all kinds of problems. And then they could actually have an ectopic growing there, and their uterus could rupture for that little bit of a horn. But they also, by having half a uterus for the birth, there was a lot less space for a baby to grow. So there's higher rate of miscarriage and prematurity, and the baby being breached, all kinds of things. The reality is many women have things going on for their uterus that they had no idea about. And I think this is a humbling thing to realize, we think we know our bodies and everything like that. And yet at the same time, honestly, I am not a cardiologist. If someone were to tell me something about my heart, I'd probably say, okay, I believe you for that, and that's not my expertise. The reality is the uterus is much the same way, and its ability to sustain a pregnancy and to hold it very much depends not only on how you were born, but also how you evolve and grow over the course of life. And so while Mullerian anomalies, which is just basically the uterus starts off as two halves by the kidneys, it comes together, fuses in the midline, and resorbs to form a single cavity, not everyone gets that. And so we can see some really unusual and funky variations that have a meaningful impact on whether a person can successfully have a baby. A lot of other things can happen along the way. People can get fibroids, they can get polyps, they can get scarring and infections. And then there can also be all kinds of things that go on and by the way, so many good people I'm seeing coming on. Hi, I gotta say that. Love you all. Thank you for being here. It feels good to have this engagement and positive energy for everyone who's here. There are all kinds of things going on for fertility that can be accumulated over time. And that also can relate to the tubes. It can affect the eggs and then the sperm. This is one thing I always say. People overcomplicated fertility, and they're saying, you need your hips in the air and boxers instead of briefs and cold showers and Geritol and Robitussin and pineapple core and salty McDonald's French fries and all these kind of things. And of course, none of these things really change where you are, what you do for stuff. What really matters is ultimately having the right DNA building blocks for people to have a child. So they've got to have good sperm, got to have good eggs, they've got to meet in the tubes and have a place to go in the uterus. So of course, good, healthy parts of the body are essential. So we talk all the time about doing that. Now, what are the things that people really often think that are going to happen that don't always change things? One of the things that I think really should go on, or that should matter for stuff, is that people try to blame themselves. They try to say, my fertility is in my control, my fault, my life, and if I don't do X, I won't be able to get pregnant. You gotta look back and say, oh my gosh, there are all these people who are doing all these crazy things and they're getting accidentally pregnant. If this were make or break, we would have all died out as a species for getting it wrong. We would have done silly things. And it's really important for people to say it's probably not their fault. And in fact, some of the things people try to do, they can actually make themselves even worse. And this is really important to know about and for things. There's a study that actually showed for a lot of people, it was out of the Netherlands, and it showed all these people taking all these holistic supplements and doing all these natural things. They actually got themselves in trouble and ended up worse. They weren't allowed to tell their doctors what they were doing. So, rather than people, I think there's some people who are embarrassed to tell their doctors, hey, I'm doing this on the side because my friend on TikTok recommended it. You know what? Just tell us, it doesn't matter. But the people who didn't tell their docs, they ended up with a 40% lower fertility rate. That was how negatively they were doing. It wasn't that some of them couldn't have found something that worked well, but they were more likely to get it wrong than right. So your ability to have a good connection and to work with people and know each other and share and talk, is this the right thing for me, for others? That makes an enormous impact on who ends up successfully having their families. So that's one of the things, but it's not always make or break. The next thing that is kind of important, beyond just saying, hey, what do I do for my free time, is what constitutes wellness. And by the way, I like for people to eat a bit naturally. Hey, I'm married to an environmentalist, that's on my list. But I can walk into McDonald's and you'll see people surrounded by a litter of kids. So don't think you have to have the perfect diet or live at Whole Foods in order to be successful. And all the supplements and all these, you see crack babies out there. These are kids conceived not in the best of circumstances. Our ability to actually, have perfection to get where we want to be, that's not usually going to be anything that drives stuff. By the way, I'm not seeing any questions yet, so I'm going to keep rambling on things on my mind. If I don't have questions or you guys can give me stuff, I will take any topic that's given to me. I'm a big believer in saying what's relevant and what's important, and I'm just adjusting some plugs for everything like that. But definitely give me some topics for things, and I'll take it all. But I think the ability to take the blame off the self. So here's the thing. Losing weight sometimes helps, unless you're anorexic already. Obviously, that's not good. But at the same time, I think people need to hear, hey, you know what? Losing weight, it's really shame and blame a lot of the time. A lot of times people say, oh, you need to lose weight to get pregnant. What they really mean is, I deserve my kids and you don't. They don't realize they're that tacky or crude. They absolutely are. The reality is, if a lot of the building blocks for fertility, sperm, eggs, tubes, and uterus, if a woman loses 5 pounds, it won't improve the guy's sperm. If you lose 10 pounds, it won't, if you had lost an ovary, I would say this to a person, she had it removed. You know what? Losing 10 pounds won't cause an egg to regrow or an ovary to regrow. Losing 20 pounds won't block tubes. Losing 30 pounds, fibroids won't go away. So there's a lot to fertility that weight actually won't impact. Doesn't mean don't be well. Avoid gestational diabetes and preeclampsia and stuck shoulders and death and all kinds of things that go into it, but it absolutely matters. Now, got a great question from Mackenzie on here saying, how many eggs and what size eggs do you like to do IUI? And I've actually got a table when I'm teaching this to men's students and OBGYNs and residents, all kinds of people. I have a table that's about this big. Well, depends on how big you want to make it. But it says who is the right amount for the right person. And I think that's the really important question for it. The person who's, so there are a couple variables I really look at. If you have, you never ovulate, then you've had 0 eggs and sperm ever able to meet. Or for instance, you're using donor sperm, lesbian couple, or the tubal reversal, sperm and egg never met, now they are. You can go with far fewer eggs for things. And so the thing is, the younger you are, the more likely the eggs are chromosomally normal, so you need fewer eggs. The briefer you've been trying to conceive, or circumstances have never given you the shot before, the fewer eggs you need, and the less therapy you've done before, the fewer eggs you need. However, as you get older and eggs are more chromosomally abnormal, as you've gone 12 years, and you have regular cycles, so you've had 144 times eggs have released and sperm didn't meet, or they met and things didn't go forward, you can be pretty aggressive when people have had a longer journey with little risk, not zero, but less risk for multiples and complexity. And then I tend to lean a bit more towards above 20 millimeters. There's an art to it. You don't want to get too far in. You don't want people to ovulate. But I think part of this art is why we see higher pregnancy rates in our practice than the rest of the U.S. Classically sees for things, because we're able to be a bit more aggressive about things. So I'm proud of the team, everything we're doing on that. But I also think a part of it is going a little bit larger. We often are going, again, 20 to 23 millimeters instead of the classic above 18 millimeters for things. Are there specific circumstances in which IUI is better than time? Asia's asking this. Are there better specific circumstances in which IUI is better than timed intercourse without sperm issues? Really good question, and a bit complex. Now, there's some purists who would say you only should do IUI because there is a specific male factor, or, and it's not that you can't say, there isn't, clearly if there's a male factor, sperm, if a guy has 5 million total motile sperm, that means every other month one sperm might find an egg. You know what? Going up to 25 sperm finding the egg through insemination, that's a huge boost. But I would say in most cases, IUI amplifies fertility. And there are more sperm to find more eggs. And the reality is everyone's trying to say, hey, here's some pills, let's get some extra eggs, but increasing the number of eggs increases the risk for multiples. Increasing the sperm doesn't really change the amount of multiples. If you took a guy from 5 sperm finding an egg in a month to, 250, there's still only the 1 egg or 2 eggs or 3 eggs. And so you don't usually blow people out of the water and give them multiples through IUI. So you can amplify fertility without necessarily increasing as much risk for complications. The core thing where I find that actually doing IUI relative to timed intercourse, where timed intercourse is, for timed intercourse, if sperm and egg, again, have never met, and you're doing ovulation induction, so they're going from 0 eggs to 1, that's a really good point to say, hey, let's let sperm find things naturally. But otherwise, and again, I think there are a lot of places that overcharge for inseminations. We're doing an ultrasound insemination for around $550, $650 per month, depending on how you look at the numbers. And so if you're spending half of that on the ultrasound, or a third, if you have a 3, 4 to 12-fold, then you can play around with the numbers for how much of a boost it is. There could be a huge boost from IUI. Dollars spent per pregnancy achieved, you're getting pregnant faster and cheaper relative to sort of pills and timed intercourse, in most cases outside of those where people just never ovulated and now they can. So what I would say is people should have autonomy, freedom, the ability to do what's right for them, but at the same time, you don't want people to waste their money, and getting pregnant more slowly at greater cost and more expense isn't what most people are looking for. And so this is why for most people we lean much more into diving straight into oral medication with insemination relative to just going on for just pills. Here's the thing when people talk about just doing pills, which a lot of people, by the way, do as a natural approach. When it comes to pills for fertility, everyone says, oh, I'm not getting pregnant. Hey, my doctor gave me Clomid. Now, first, Clomid, I think, turns everyone into the devil. All the hot flashes, I do not like Clomid. I almost never give it unless rare exceptions or people ask for it saying they prefer it, which almost never happens. But here's the thing. If you have someone who's 30 years old, year and a half of unprotected sex, I want all of you to think about this number. 30-year-olds, 18 months unprotected sex. Doesn't mean they've been trying deliberately. They just haven't been using contraception. What's the pregnancy rate per month? I ask this question all the time, and OBGYNs and even fertility doctors get it wrong. 30-year-old, 18 months unprotected sex. She's not running 20% a month. It's 2%. She should have been pregnant multiple times. If about 75% of women get pregnant in 3 months, you can argue that, she should have been pregnant 4 or 6 times by now for things. And there are all kinds of people I've got to wave out to, by the way. I'm just one person. Glad to see we're showing up on your feed for things. We miss you guys too. If you're saying that a person's running 2% a month for their natural fertility, and the most common intervention is Clomid, which we don't use, and you are saying you've given them, instead of 1 egg per month, they got 2. How much did you change 2% a month by giving a person a second egg? You didn't change sperm, tubes, or uterus. You took a person from 1 egg to 2 eggs. They were running 2%. You know how much they go up to? It's around 3.2%. Or call it 3. The average person who's taking pills, who's ovulatory, changed their fertility by 1% a month when they take pills. That's it. And if they've had a longer journey, it's even less of a boost. And that makes sense. It's not even a doubling to go from 1 egg to 2 eggs, because there's more to fertility than the number of eggs you get. So therefore, that's why you get such a subtle shift. In fact, when women take Clomid who are ovulatory to improve their fertility, if it's only taking from 2% to 3%, it means the majority of women who got pregnant would have gotten pregnant without the Clomid. That is a paradigm shift. That's something nobody tells you about for how fertility works and matters. Conversely, when we do fertility often, and you got that same 2% woman, and we do pills plus insemination, and we do letrozole again, and you go from 2% to, with 2 eggs, often 15%, or 3 eggs, 20%. 15-20% is a 1 in 6. You give it 3 months, you roll a dice. You get 6, you're pregnant. 1 through 5, you're not. 3 rolls of the dice, about 40% of people are pregnant. So instead of going from 3 months a 6% chance to 9% with pills, you're going from 6% to 40%. That's a lot more likely to get people where they want to be and to improve their odds and hopefully get them to have the families that they want. But most people don't realize it. They just say, hey, my doc gave me some pills, and a lot of them can't do the monitoring, they can't be assertive, and they've got to make sure that there are things that actually make a difference for people getting where they want to be. You don't want to be going through pills and insemination and have your tubes blocked. Don't waste your time or money if sperm and egg aren't going to meet. Or some people need to do it to prove that they've done everything that they can for trying to conceive. So that I respect. Because honestly, HSGs can cost a ton in a lot of places. So if you can do pills and insemination, give it a few rounds of trying without actually spending less than you would have on HSG, and you actually had a shot for it, that makes sense for a lot of people. Okay, great question also coming out. Asia, she's got the next really good question, and again, everyone ask away for anything. Is it true that there seems to be a larger influx of infertility issues in today's society versus before? I would say yes and no. So there are a couple things that go into that. So the first thing is, I think the whole dialogue around fertility has changed as a society. It's not that, it didn't exist in the past, but oftentimes people just say, oh, that was the aunt who decided to raise cats. And by the way, love women who love cats, there are a lot of good things on that, but basically it was that we as a society didn't really recognize that they were single and relationships had changed just because they couldn't have had kids. And that was an essential part of family building and relationships. And it just got buried. And also people couldn't talk about it. And when they did suffer, they suffered in silence. I think one of the things, social media, a lot of things have been complicated in life, but I think our ability to get out there and hear other voices and to, recognize we are not alone in things is huge. Now, are there things that are driving infertility as well? Some. I think the number one thing that is driving infertility is people having children later in life. Now, the number one thing, by the way, that seems to drive that, they did these studies out of the Netherlands. The more women were in the workforce and the more they were paid, the fewer children they have. And that was definition of who people are and as a family. Now, again, I value my wife who's working. I am surrounded by a team of nurses who are phenomenal women, and front desk and embryologists. I don't know why I still have a Y chromosome practically at times for how much estrogen I'm surrounded by. But at the same time, I truly have to go where the data is and acknowledge that these variables change people's choices for reproduction. And the fewer children people decide to have, and the later in life they choose to have it as they develop skills and careers and things like that, the older you are, the more likely a problem has accumulated that makes it harder to get pregnant. And that includes tubal disease, that includes things for fibroids and polyps and all kinds of other issues that can come up. And so I think those are things are reasonable and relevant. And then also the fact that something could be done about it changes how we think about fertility. So it's very interesting. When I started out this shortly after the earth cooled, I've been doing fertility a while, a little longer than this Doogie Howser face would have you believe. When I started doing things, the UK, a few years prior, had come out with a survey of priorities for healthcare. And they'd ranked all these things and sent it out to the general population and said, hey, what do you think is important? And out of, I think it was 750 priorities, I think fertility, doing IVF came in at 706 or something. It was one of the least valued healthcare opportunities. And it was ranked behind tattoo removal. And that just pains me to no end that people don't appreciate other people's suffering and the importance of family. And I think we're getting to a better point than we were with that survey. But now, I think while we are now more aware of things and we are more open to others' needs and supportive of them, I think also our ability to talk and think about these things, it does come in part from the fact we've become more effective in identifying what's relevant and then treating it. So there's also hope. It's not just that fertility in general is important, but then the fact that you can understand it and act on it, that make a world of difference for things. Got another good question from Haley for things. At what point do you decide that it's time to try IVF after doing IUI? So I'm going to say a line that I just heard probably in the past few months. I've never used it in over 20 years of practice. I'm using it all the time now. And I tell people, this is a buffet. It is not a force feeding. I really believe people need to do what's right for them at their own pace with freedom and autonomy. So I would say any decision for what therapy you choose is personal, and we'll still tell you, hey, this is what's on the menu. This is how this dish might fill your belly. And, to extend the analogy, this is what's probably going to taste good. But I think that has to be individualized. For where I look at IUI after IVF, now I'm married to an economist. My wife talks dollars spent per pregnancy achieved. She looks at financial efficiency on things. And I start seeing diminishing returns with IUI. The longer I go, the more likely that you're just someone for whom it isn't going to work, and they're just things that medicine doesn't know. But I've seen interesting things with IUI, and I'll come back to some of those exceptions. If people are going to miss a window of opportunity for IVF, that's where I start leaning a little more towards fast tracking towards IVF. If people have blocked tubes, if I just don't think sperm and egg are going to meet each other, Not that I can't do IUIs. Again, some people need to prove things, but I would say for many people, the ability to do to go into IVF and just bypass the tubes makes a world of difference. I think a lot of people also don't do IUI because they are worried about genetic issues that could potentially be passed on. So you can find, hey, this pregnancy would have Huntington's, would die very early. This pregnancy has this lethal condition. We want to make it so that you don't automatically miscarry. These are things that absolutely matter. Generally, though, I look at how much people have for time for things. So, for instance, if you've got plenty of eggs, you are 30, I see an antral follicle count of 24. Antral follicle count, by the way, versus AMH and all those things, and why I don't do OR testing and all those other things. So that's a whole nother topic, and someone can ask me on that if they want. My logic and reasoning is if I've got time, I can do low cost, low tech and get people pregnant. That works really well. But the thing is, if I have a person with 3 eggs getting 20% on the first round, by the 4th round, I might be only more of a 10, 12% with those 3 eggs. And if I start getting past round 6, I might be 3, 4, 5%. There's just a point of diminishing returns. And so the longer you go with less to show for it, the more likely you're to say, you know what, we just may need to really bypass the tubes. I would also say for when there's stress where people are saying, you know what, I've done IUIs, I just can't, I've got to rev it up. And another thing for going on to IVF, by the way, is family or fertility preservation. You know what? You can have a 38-year-old, and so many you can get pregnant with IUIs and low-cost, low-tech methods. But what about that next child? 9.5 months of pregnancy, a year of breastfeeding, and she may have lost half of her fertility in those 2 years for her inherent chances. It may be good to actually do IVF, bank a few embryos, and then you can go back to IUI, see what you can get. But people who will lose an opportunity, that matters. But generally, I tend to stop a bit more at 6, and then there's some people where it's just right to stop after 3. Now, this is one very important difference for how I see this lens relative to many people. Most people track very fast onto IVF. Most people are charging $1,500 or so per IUI in the US. That is incredibly expensive. Now, again, I also see a lot of people charging $5,000 for a transfer in the US. That also seems crazy expensive to me. But if I can do 3 ultrasounds and 3 IUIs, and I get about 40% of people pregnant, as long as they are of a reasonable age with good ovarian reserve, reasonable sperm, and open tubes, 40% chance you're pregnant for $1,500, that makes a lot of sense relative to a $20,000 solution. And there are ways of doing it for lower, by the way. There are all kinds of stuff for nuances. But the point being, how do you give people value? I always phrase it this way. I say to people, look, we want to save you a lot of money for decorating the baby room and the kids' college fund and all those other things. Let's find something that's the right balance for you on these things. And so I'm game for whatever is right for people. And I think the key thing is also where you start out from. That doesn't mean that's where you'll end up. This is one of those things where actually also, if you are not pregnant after a few rounds, you really need a good discussion with your clinician to say, hey, what do you see? This is one of the most valuable things I think that we do as a practice. And we do this, where basically if someone is, by the way, we've got you're hearing an alarm outside. That's the first of the month. On a Monday, the fire, there are no problems, there are no tornado drills. I am safe for things. Hope everyone else is. The point being that, actually, you know what? I heard the alarm and I got on a tangent. I completely lost my train of thought. So you guys are going to have to refresh me and put me back on it or give me more questions for things. But I think some of it was, economics of fertility, where I greatly value it. And I would say that's where I was going. You basically, whenever someone is not pregnant with 3 rounds of pills and insemination, we just get back together and we do a debrief and we say, here's what we think is really going on for you. Where has your body been? What are the building blocks? What have we started with and we are trying to overcome? What have we done about it? So how have you been treated? How has it gone well? Could there have been things that have been refined? Be honest about what you've learned about people over time. And then what can you do to further enhance those chances if you're going forward? And what do those numbers mean? And are there any other tests? By the way, this is something that's kind of a bit controversial, but I think needs to be said. A lot of people are being passionate about fertility, and they come to me and they say, okay, Dr. Parry, I didn't get pregnant these 3 months. A lot of people do. I'm happy when they do. But when they don't, this is reality. What should I do next? And for many people, I have to say, it's not like we were waiting for you to fail to say, here's the real secret of what you should have done all along. We need a very transparent and open discussion. And really even if there is something you are holding back off on and not doing it initially, you need to have that in the initial discussion and say, here are the things we're doing. Now, if you get to this point, we'll consider this, but that should have been part of the initial plan, not you failed. Hey, now let's see if there was anything we could have or should have done. So thinking about the best from the beginning. Okay, now Iris has asked a very fun question, and it's going to get into some super nerdiness for me. And by the way, talk nerdy to me. Ask me any details you want to know about fertility that dive into deep data. The process of periscope versus HSG. So we, as many of you know, pioneered a way of looking inside the uterus. To my knowledge, for looking at the tubes are open with hysteroscopy through air bubble infusion, or you can use other contrast agents. When we presented this at the American Society for Reproductive Medicine in 2015, to my knowledge, no one in the world had ever presented this before. I haven't found evidence of anyone ever presenting it before we did. And it was a technique to say, how are we looking systematically at the pelvis as well as understanding the tubes through using hysteroscopy. Now to step back for HSG, a hysterosalpingogram, it's an X-ray dye study of the pelvis. It was invented in 1910, and it was first described for the tubes in 1914. So it's around, it's over 100 years old. And I argue it's one of the most barbaric tests that still persists in modern medicine. There are not many things that people still do the same way over 100 years later for medicine. HSG is one of them. It's a hysterosalpingogram. And so what happens for a lot of the technique, you go into radiology, and so you go off into a hospital. Some people have it in the office, but a lot of people go to radiology. And they place a speculum, and then they grasp the cervix with steel hooks. It's called a tenaculum. Now, by the way, I do not think steel hooks should be belonging in any part of the gynecologic anatomy for an awake person. Sometimes, you need instruments to grasp things. That's the nature of procedures. But it's just barbaric. Oh my gosh. And it hurts. And then you're trying to introduce a dye into the uterus, and some use catheters and some use various balloons. There are various things that can be done for that. But then you're trying to fill the uterine cavity with this dye, and hopefully it spills out the tubes, and you can get actually a sense of the shape of the tubes as you do that, and hopefully the dye leaves and exits into the pelvis. The problem is a lot of time the tubes don't behave themselves, and sometimes there can be spasm, and that can keep the tubes from acting open. And so what a lot of people do to sort of offset that is they actually use force. And so they are trying to blow the tubes open. And this can hurt like heck. And in fact, I always say sperm don't swim in the jaws of life. They can't prop open a closed tube. But there's this really big myth out there that you are flushing the tubes. Now, not everyone agrees with my view on this, but I don't believe flushing the tubes actually really changes much. I think the data even showing that oil-based relative to water and some other things, but like that, I'm not as convinced by that data because the oil doesn't last. There's some technique things that went into these, and the reality is you can do laparoscopy and chromopertubate, and you can see a little debris, but mucus and debris accumulate in a lot of places. And you know what? Just like menstrual blood comes out, so does some stuff from the tubes that just gets sloughed over time. And it's not like you build up like, you forgot to take the trash out on Tuesday, and now all of a sudden you've got this huge, debris that's filling up your entire tubes, and people can't get pregnant. That's not how the body really works. And we actually see a lot of people, by the way, get pregnant after we do the hysteroscopy, where you're also having saline dispersed through the tubes to see if they're open. So relative to doing something where you are using an X-ray dye study, so you're getting X-rays, and by the way, people can have allergic reactions to the contrast, and also it's a 2D black and white image. So a lot of times actually there can be disease within the uterus, like polyps or infection or scarring, and HSG is not particularly good. Hey Macy, gotta wave to anyone doing call outs and respond to everyone here. When we do periscope, so where the name for this came from was we're trying to be specific, and we're saying, hey, don't just look inside the uterus with hysteroscopy, but you've got to be mindful of how gentle you are, how small your instruments are, what you're able to see, what your resolution, all these types of things that go into doing it accurately. And so we want to, where people started using the periscope name for it was because we'd pioneered it. Periscope as the trademark name actually means minimally invasive surgical surfaces, as well as for a website for information, as well as for devices. But where we were going with this was that there's a specific way of being accurate. And what we said is you've got to use a really tiny camera first. That makes a difference in what people feel. And so we said, 2.8 millimeters or under is that. So, and where that 2.8 is, by the way, that's small enough to go in the male bladder in the office without anesthesia. So if you're looking in the uterus with a camera that's small enough to go in the guy's anatomy, if it can go through the guy's anatomy, most women can handle it fairly well. The next thing that is meaningful for, looking inside the uterus and doing this accurately is you want to have an empty bladder. The bladder, so that the air bubbles can rise to the tubes. There are ways of doing it again with other fluids. And you're going to see if those air bubbles jump on through the tubes. And if they go through, the tubes are open. If they don't, the tubes are a lot more likely to be closed. But it's allowing things to reach the area naturally. Through low pressure, you're not forcing anything. And then what they find, by the way, and this is getting back to one of the core concepts, if you have to use high pressure to show the tubes are open on hysterosalpingogram, so you have a lot of pain with it, there's a study by Gleichart in the 1990s which showed that painful HSGs, actually showed 1/4, I should know what for, I'm doing the numbers, 1/4 the fertility as people who had the tubes open without pressure. So, and this is something that nobody talks about for things, but the reality is also for laparoscopy, a lot of times people are using so much force they can actually say something's open, and sometimes there may be a bit of damage and it doesn't reflect the normal physiology. So we're trying to say, what is a low pressure system to see if the tubes are open? By the way, just got a question as to whether we take Blue Cross. Right now, we're taking Maven and Progeny, but if someone is wanting to submit to insurance, we find insurance often is horrible for covering things, and you'll see a lot of people where they have these super high prices, and then insurance makes them knock it down a bit, and so that they can get to normal numbers. But then some people pay these super high prices. We all just say, look, we're going to be out of network, just like a lot of people do for dentists, and we're happy to submit things to your insurance and see if they cover, and then they reimburse you. And you're more likely to get reimbursed than we are. But a lot of insurers do a bait and switch, and they reimburse below cost, and that's not necessarily sustainable. So we try to do things that are fair and realistic. And I find that, for the cost of our testing, we are even out of pocket, we're finding more at lower cost than many people pay with their insurance. In fact, with their copays and deductibles, they're often paying. I can't tell you how many people I've seen go somewhere else because they want to use insurance, and then their benefits end up being lousy, And then they ended up paying more by using their insurance, and then things were missed, and then they spent all this money on fertility therapy, and then they got the wrong diagnosis, and then they didn't get pregnant because the right things were treated. So for us, for instance, a consult is right now $150, and then the testing, the ultrasound plus hysteroscopy, colloquially known as periscope, that is $1,000, and semen analysis is $75. So you can have your full testing consult, for about $1,200 for things. Now, again, some labs insurance are good on picking up, and so then we send that off to insurance. But at the same time, also if you're looking at many people for IUIs, they're paying $1,600 a round or so, and we do 3 ultrasounds, 3 IUIs for around $1,600. And we're getting higher pregnancy rates. If you are charging a third as much as most people for twice the pregnancy rate, that's 6 times better value than most people get for things. Well, see that? I'd love to see you. And by the way, this is not, when I'm talking about this stuff, this is not a solicitation for services. I am happy to see anyone. I'm happy to help anyone. And here's the thing, and for this. And Iris asking, is this only available at Madison? So we are Madison, Shreveport, and Slidell. These are all geared for pretty much everything. Slidell, we haven't started doing retrievals. Gulfport can still do IUIs, can still do semen analyses, ultrasounds, hysteroscopies, everything. For Starkville, then I would come to the Madison clinic. The Starkville satellite we have is once a month. We go out there just to make it easier for people. But for having the full team, things are much more on the Madison side of things. I've gone on a lot of tangents, so please get me back on track to anything else. I think we were talking about how you do testing for things. One of the things that's really important, I think, that just people should hear is, yes, the tubes are the number one thing I see. In fact, I see about 40% roughly of people with a degree of tubal disease. And it doesn't mean both are obliterated. It could be one blocked, the other open. Also, an important thing that when people worry about tubal diseases, they're saying, my gosh, my tubes, I haven't had a history of gonorrhea or chlamydia, ruptured appendicitis, or endometriosis. I should be fine. But actually, for endometritis, which is one of the top emerging things, and by the way, we see this when we do hysteroscopy and look inside the uterus, and you wouldn't see this normally with ultrasound, you wouldn't see it with HSG. When you look inside the uterus and find endometritis, it's a low-level infection. When I say endometritis, by the way, people hear endometriosis. No. Endometriosis is the lining of the uterus outside the uterus implanted in the pelvis. Endometritis, think tonsillitis, appendicitis. It is an inflammatory state. It is the lining of the uterus being inflamed. And when you find this, and we've published this, you can find a 5-fold increase in tubal damage from this low-level infection. In fact, there are some people with low-level endometriosis, where endometritis precipitates endometriosis, and you treat their endometritis, you can actually potentially improve their endometriosis, which is really weird for a paradigm shift, but this is one of the things I think is coming down the pike. Not all endometriosis, again, very specific circumstances, and you have to find this inflammation of the lining, but then it may treat stage 1 endometriosis, possibly a little bit of improvement for stage 2. Stage 3, stage 4, completely different. But 15 to 20% have this bacteria normal to the vagina that made its way into the uterus. And if it gets there, then what you can have is it scars the tubes at 5 times the usual rate. More than that, and this is something nobody talks about, one of the things people say, I had a miscarriage, do I need a D&C? And I actually wrote an editorial in our national journal recently on a publication. This is from Tommy Center for Miscarriage Research. It's out of the UK. And they looked at women who had 3 miscarriages. And they said they looked at women who had 3 miscarriages where it was spontaneous or pills. And they looked at and compared them to women who had 3 miscarriages by D&C, that were treated with D&C. And the women that had the miscarriages, and Haley has a great question, and it's going to relate to that. The women who had the D&Cs were 50% more likely to have a subsequent miscarriage than the women who had just pills or that passed things spontaneously. So we've got to be careful about how we do manage the uterus when people are having miscarriage. But here's the thing, it's not everyone is equal. Women who've had endometritis, that inflammation of the lining, that actually can make things a lot worse. And you see a much higher rate, 2, 3, some people even argue more fold increase in damage and scarring to the lining of uterus for people who have endometritis. And that really matters. When people identify endometritis, we've got to say these people are more delicate and should be handled differently from other things. So back to Haley's question right here. How do you reverse the damage that endometritis left? You can't entirely. That's hard, that's horrible, it's true. You can prevent it from getting worse. Now, if I get an abscess in my arm, and there's an infection here, I'm going to get incision drainage, I'm going to let it clear out. I'm also going to have antibiotics to get rid of inflammation. And then after it's been cleared away, I may no longer have the infection, but I may have still where that skin just looks a little different, healed a little funny. And I think there's a degree to when people have endometritis, there is a degree of baseline damage that exists for the uterus, so they're never going to be fully back to normal. But at least by getting rid of the infection, you aren't letting it get worse, and you're having at least a better setup for the future, for things working. One guy named Ciccinelli out of Italy, he's a great guy. He's one of the pioneers for endometritis. He said, if you find it and treat it, you can actually even see a 6-fold increase in the likelihood of live birth. I usually quote 4-fold, but and people debate this. I think how we diagnose so I think where we are for endometritis in 2026 is where we were for endometriosis in 1976. I think we're barely scratching the surface, and I don't think we have agreement on how to test for it or how to treat it. I do think the biopsies, which are painful, they only sample a little bit of the uterus, so it's easy to miss things. Endometritis as an infection, if you are putting in a catheter and scraping the uterus and biopsy, which by the way hurts as much as HSG for some people, so I'm not a huge fan of that approach. You put that in, you only sample about 4% of the uterus, so you can miss some stuff. And so you have to have a really prominent or severe case in order for that to pick it up. But if you go in with a hysteroscope, you can see that there's some up here and some down here, and if you are biopsying in the wrong place, you missed it. And more than that, people have done research on this, and they tried to biopsy those areas, and they can find there are different bacteria up here relative to down here, and so there may even be different bacterial sensitivities. So we've got a lot we've got to figure out about that. But generally, a single course of doxycycline, for our current understanding, often will treat 85 to 95% of cases. And so for me, if I see that, I'm just going to say, you know what, I'm not going to do a $1,500 biopsy where I might miss it to decide whether I should do $30 worth of antibiotics. I'm just going to give the antibiotics. Dollars spent for pregnancy achieved. Be efficient. Don't waste money. And I think there may be algorithms we come up with for the future where there's more advanced testing. But I would say, I think there's so much that should be done with hysteroscopy. So this is something else people don't talk about and is really meaningful. If you look at IVF, just for a second, we published this in a journal a few years ago. We did a systematic review and meta-analysis. And we said that if you do hysteroscopy before IVF, I think you're 25% more likely to get pregnant. I think the risk ratio was like 1.23, something like that. And if you did IVF and you failed, and then we're going to do another cycle, your risk ratio was 1.43. So if you had failed IVF and then you did hysteroscopy before your next cycle, you're 43% more likely to get pregnant. I have to look at numbers. I might be off, 1-2%, something in that range. And if you did IVF, and then you had done hysteroscopy and you found disease and treated it, you were 2.1-fold more likely to bring home a baby. So I think there is emerging data that is suggesting, and I don't think everyone's caught up on this. And so I'm not saying this does not, our national guidelines are looking at this. They are not fully there yet. But I would say that we are probably going to be reaching a point where hysteroscopy is essential for good outcomes or maybe that's not the right phrasing, but it is an important part of people getting where they want to be for fertility testing and IVF outcomes. So, and the reason people have not done hysteroscopy, it's always been the gold standard. It's that most people are doing it painfully. They are doing it poorly. They're using large instruments. So I remember, someone from the UK saying that I was making up that we could do hysteroscopy gently, that it didn't exist. And he was really mad at me for things, and this was a decade ago. But that was because people in the UK at the time were using 5 and 6.5 millimeter hysteroscopes in women who were awake in the office. Oh my gosh, that's brutal. I'm talking about using tiny cameras. You have to use and again, they don't conventionally make equipment that for gynecology that should be used for office hysteroscopy. Now I'm going to get on a soapbox for a minute here. This is something I'm very passionate about, and this is part of why I teach. I take time, I lose money by going out and teaching. People don't realize this. They say, oh, you're playing for a conference. You know what? If you're not in the clinic, you're not seeing patients. But I believe in this. This is essential. I believe hysteroscopy to be a social justice and gender equity issue. If you look at ENT, ears, nose, and throat, they view looking in the nose with a camera, inseparable from the physical exam. You look at urology for the male. 98% of urologists can do small caliber flexible cystoscopy to look in the bladder without anesthesia in the office. Probably, the estimates I've seen, and the numbers can vary, about 20% of OBGYNs perform office hysteroscopy. Fewer than 10% do it routinely, maybe 15%, but somewhere in that range. And fewer than 1% use instruments on the caliber of urology for it. Women actually get less accurate, more painful care as a result of disparities in access to technology. This is why I say good office hysteroscopy is a social justice and gender equity issue, on top of being something really valuable for helping fertility. And so for me, I deeply want to train anyone on office hysteroscopy where I can. By the way, this October, I'm giving 2 talks at our national conference. One is on how to take hysteroscopy out of the operating room and do it in the office. The other is on scarring and adhesions within the uterus, something I was alluding to before. So I'm privileged to be speaking and teaching at our national conference. By the way, I did this at Hardis in Rome in April. I was at the Mayo Clinic training fellows in the field of infertility in May. I'm going to the AAGL in Boston in November for teaching on all this stuff. I'm very privileged to have the opportunity to help move the needle forward. And I couldn't do this, by the way, without all of you guys. I really appreciate you because when you share and you come on this and you talk about it and tell people about us and what we do, it's not just, hey, you're helping friends become pregnant, for fertility, for things. But also when we talk about what we do for testing, it is the more women are aware that there are better ways, gentle, accurate, safe, effective, affordable, the more that moves the needle for the field, and the more that forces other people to do it as well. I truly believe we're part of a movement when we talk about how we are understanding the pelvis better. We're setting up for a generation of other women to not have to go through everything so many of us did. For having more painful tests, for having less accurate information, for being told it's unexplained. It isn't unexplained if people didn't look. And so I think all that you guys do to advance awareness and share this is actually helping protect a whole generation of women. So thank you for all you do, as well as giving me the opportunity to speak on so many of these things. Um, Hey, Carly, good to see you there. By the way, all right. Oh, thank you. That is so sweet. Yes, it is so fun for things, when people are, posting on their kids and having them. So one thing we do as a team, by the way, that's really fun. Um, the week before Easter, every year, well, usually it's the week before. Sometimes we do 2 weeks before. We do a baby reunion. So everyone who's, people who've come through, had a child, and want to show up, we do pictures with the Easter Bunny. There you go. I know. I can't. By the way, there's a lot of things on here that are HIPAA violations. If I were to say it, but they can say whatever they want. So there's autonomy freedom. But I'm smiling as I see things. But people are able to come, and so we searched for their eggs. Now they're able to come to us and search for eggs with the in the clinic, and we have pictures with the Easter Bunny and the whole team, and it's this beautiful circle of life. So I will tell you, my single favorite day of the year is Baby Reunion Day. And just to see all these people I've known, and they're finally on the other side, and they have that baby in their arms, and celebrating, and honestly, I messed up. 20 years into a field, you should be, as some people are jaded. This is the most wonderful and miraculous privilege to be in this job that I have, and for all of us to be together, I really appreciate that. But to see people on the other side, not only is it so exciting and wonderful, but I actually, my cheeks hurt. I literally collapse afterwards. I am exhausted from all the emotions and the big feelings, and but I've been smiling so much I can't lift my cheeks anymore, because I'm even misting up a little bit now as I think about it. Because I'm just so happy for the successes. This is such a hard field. It's there's a biography of Louise Brown, world's first IVF baby. By the way, her birthday was a little over a week ago. The world's first IVF baby was born July 25th, 1979. So she just turned 47, and she's a wonderful woman. I have pictures of me with her, and she's really nice. And the Steptoe and Edwards, Edwards won the Nobel Prize for inventing IVF. And he had a wonderful line in Louise Brown's autobiography where he said, the credit, and it was a reunion at Bourne Hall where Louise Brown was first conceived. And by the way, if any of you haven't seen Joy, the movie on Netflix, wonderful movie, you got to see it. And by the way, the name Joy, it's not because of the joy of people being pregnant in IVF, but it's Louise Joy Brown. That is her middle name for the title of that movie. But he said the credit, I believe it was Edwards, said the credit, yes, some goes to the doctors and the embryologists and the nurses and all the staff that go into it, but ultimately so much of the credit goes to the women who've been wondering, worrying, enduring pills and shots and scans and procedures and the negative pregnancy tests and the miscarriages and all the struggle they go through. But their resilience is what led to the successes and them being the moms and making it to the other side. And it was such a beautiful way of capturing that truth. There are so many people out there that suffer in silence, that are going through these challenges on their own and that need support. And the ability, I think, for us to be a community and to help them, that is a wonderful thing. And I just am lucky to know all the people showing up now who are, a part of this. And again, I've really enjoyed this. I've been going on for an hour. Honestly, I could keep going. I'm just warming up. I mean, you guys could be, if there are no questions in the next few minutes, I'll, sign off or anything like that. Because I could keep people, we could be here all day. Because I love talking about this. I think this is one of those things that you see for fertility that's really important that people don't talk about. It's not just a job, but a calling. It's something where you are there for a purpose, and you care deeply about the outcomes, and it weighs on you if people don't get there. So I care very deeply about things, and I think all the team does. And I'm very lucky to be, thank you. I am passionate about it, as you can see, and I think all of us are. Well, it's existential. I think this is determining who has families, how they grow, what their future is. And it is a privilege to be entrusted with that. And that's why I care so much about who ends up actually being successful. Because, here's the thing. Nobody suffers more than the person who wants a child and can't have one. But I can tell you, I messed up with miscarriages. I stay awake at night thinking about, who's successful, and whether there are ways to leverage odds. It's a purpose. And if you want a child, obviously you aren't getting where you want to be. And for us, if I don't achieve my purpose in life, it weighs upon me. And so I care very much about getting people to the other side. And I think that's probably the best thing to sort of close on or comment on. 80% of a doc's reputation is front desk and nurses. Thank you, Josh. 80% of a doc's reputation is front desk and nurses. Who I am, honestly, a lot of people's experience are through a great team. And I have to give them credit where it's due. I couldn't do what I do without their help and their insight and their wisdom and their support. Showing up on the off hours, calling people back, hey, it's time to go home. Nope, we want to make sure that this person, hears from us because this is important. I'm just very lucky for the people I'm with. I think I have talked on way too long, but I'm glad to have as many people on that I have. This has been phenomenal. I think I'll have to do this again, and let me know if you've got topics you want me to go into, and maybe whether we should do it not at a lunch hour, maybe we should do it in the evening sometime. But anyway, thank you all. God bless. Good luck. I hope where you are in your life journey takes you there. If there's anything we can do to help, if others can help, just don't go it alone. There's a lot that can be done. There's hope. There is opportunity. And I'm excited about all that we're doing and can continue to do. So thank you. Okay. And now I am not entirely sure how I shut this off. Really, truly, the first one. We'll see if I can. First stuff. Let's see. Okay. There we go. Found it.